Dr. John Lenihan, uh, retired OB-GYN robotic surgeon working now with Mimic Technologies, and I've got Dr. Andrew Hung from USC, the Department of Urology. And he's agreed to chat with me today a little bit about some of his research and some of his impressions of using simulation for training and where we're going in the future. So Andrew, you want to introduce yourself real quick?
Yeah, absolutely. Thank you, John, first of all, for inviting me to this conversation. My name is Andrew Hung. I'm a robotic surgeon and urologist from the University of Southern California, and I am the director of our Center for Robotic Simulation and Education.
Yeah, so Andrew, since you're the director of simulation and education, I know you interact with fellows and residents, and you're been through training yourself, and now you're training new people. Can you kind of give us your overview of how training's evolved since you did it, and where we're going in the future with it?
You know, John, I think my inspirations of doing what we've done for the last many years is probably inspired by the lack of proper training, I would say, in robotic surgery. You know, the haphazard, you know, why don't you take down the bladder here, and why don't you spend, you know, these few minutes on the console? Oh, you don't really know what you're doing, so it better take you off, you know, as soon as possible.
Yeah, the lack of standardization and the individual programs all over the country, everyone's different, aren't they? Yeah.
Right, and this is despite, you know, to having trained at a premier institution, super high volume with, you know,
Right.
world-class surgeons. And so, you know, my hopes were, how do you standardize it so that there is a you know, method to the madness? You know, there can be a better process. And so, you know, so that's what we've tried to work on: structured learning, proficiency-based learning, such that, you know, once you demonstrate proficiency in basic steps, you get to move up onto intermediate, then advanced steps. And perhaps a lot of this can be done outside the operating room, you know, before the surgeon has even set foot. So, you know, why should we have our junior most residents discover, you know, what each pedal on the surgical console should do, you know, during a live case? You know, that should be so, you know, easily learned on a simulator outside the operating room. So those are no-brainer things. And with the advance of all the technology, not just for basic skills, but even more procedure-specific simulation, there's no reason for some of these discoveries to be done in the operating room.
Good. And Andrew, you've been very interested in doing research, and I know you were plugging along on your research into machine learning, but then this whole COVID thing hit us, and everybody's had to stop, you know, non-essential surgeries. You know, and we've had this in OB-GYN for a long time, with the OB-GYNs taking maternity leave and being gone for 3 to 6 months. But now it's hitting urology and general surgery. So what's your impression of what happens to robotic surgeons when they don't do it for a long time? And how do you recommend maintaining skills? Do you have any insights into that?
Yeah, no, you know, John, that was something entirely unexpected. And very incidentally, we had been collecting data from all of our robotic surgeons, from our most junior residents to most senior residents. And this happened the 1 or 2 weeks before the shutdown. Nobody could have foreseen that something like that would ever happen. And we actually had to cut that study short, you know, the week that the shelter-in-place orders came about in California. And so during these 2 months where we had a lot of time to think and ponder, we were wondering out loud what would happen, you know, across the board with not only our training surgeons, but also our experienced faculty, you know, what was going to happen. And we didn't know, but we, you know, saw that as our elective procedures were coming back on board in May, that we would try to answer that question by having those same 15 to 20 surgeons come back onto our Mimic simulator and do some exercises. And, you know, I'll tell you that, you know, this is yet to be published, but I'll tell you that the results weren't exactly as I had expected. I had expected that our learning surgeons probably would have the you know, more unstable skill set, and perhaps had you know, were more fragile to this period of inactivity, and that our more seasoned and expert surgeons would probably fare better. and at least our initial results don't look that way. It actually was the other way around, that perhaps our expert surgeons, pre-shutdown had more to lose because they were performing at a higher level. And so, more of that will come out, in the next couple of
Sure.
weeks, hopefully. But that's what we've seen. And so, as a result, the pandemic is a truly unique situation where it affects almost everybody across the board, regardless of specialty, regardless of basically at this point geographic location. Whereas folks who were on maternity leave or paternity leave, sabbatical, in more isolated incidents, and hopefully work that we're doing here may help inform not only how you come back from a pandemic, but also in those scenarios of more worldly things such as maternity, paternity leave, sabbatical, that we know how to how we can respond to that.
Yeah, that's very interesting. There's been some data published out of the military for the surgeons deployed to the combat zone for 6 months and then back, and how they do. And their findings were, yeah, there was skills degradation, but their more experienced surgeons seem to be able to acquire those skills and get back up to speeds quicker than the less experienced surgeons. But your data on the fact that they have more to lose, this is a story that's evolving, I think, and needs to be part of how we train, how not only train, but how we maintain skills after we're out in practice. So.
Yeah, absolutely. I mean, speaking for myself personally, not having been on the robot for 2 months, I would say that there was a little warming up to do, and definitely are thinking twice how we can, spend that warming up time not, in the live operating room, but rather be spending it on a simulator just to warm back up. And I think that is a very valid, avenue to look into more deeply.
Yeah, and I had the same experience. I took off some time with a shoulder repair, and I was nowhere near where I thought I should have been when I came back. And it would really be helpful to get these simulators out in people's hands outside of the OR, so they wouldn't have to all trape into the hospital now. So, all right.
Right, exactly. With all the restrictions, all the restrictions of who should be in the operating room, who should be in the hospital environment. I think surgeons being able to practice outside of that environment would certainly be helpful.
Cool. Well, thank you for your insights, and we look forward to the paper coming out.
Great, thank you.